Good morning, good afternoon, and welcome to this new edition of the Cli-Courses Pacific.
Marco, non ti sentiamo più.
No.
Okay. Yeah. Okay. Okay. You are back. You're back.
Okay.
Yeah. Now. Yeah.
Are you listening to me? Can you hear me?
Yes. Yes.
Yes. What did you miss? So again, welcome to everybody. Thanks to all co-director and friends. Definitely a very strict group of friends who are supporting us and permitting us to have this new edition of the Cli-Courses Pacific. Happy New Year. I hope this year will be different and everybody of us is waiting for an occasion, an opportunity to meet everybody in person finally after so long time. And Mariano, I let you speak about today, and thank you to everybody again.
Okay. Thank you, Marco. Again, thank you to everybody to support us in this new project about Cli-Courses Pacific. Thank you to Imity for the fantastic organization as always, and thank you specifically today to BD to support specifically this session. We are talking about the approach to in-stent occlusion in CLTI settings, and not only the atherothrombectomy philosophy. We will have multiple case presentations from Germany with Sven. Welcome, Sven. I will show a case about BTK. Finally, we will discuss again with Sven and with Steven from Singapore. Thank you, Steven, for your participation about the philosophy of atherothrombectomy. So I think we can move forward and start with Sven.
Yeah, thank you very much, Mariano, and also thank you, Marco, for the invitation. Hello to everybody. I guess good evening is the correct thing to say to Asia now. And yeah, I'm very proud, very happy, and it's an honor for me to participate here in this session and for the opportunity here to talk about our last or long-lasting experience with the atherothrombectomy in Leipzig. So I want to start here directly with my presentation. Can you see it? Can you see the slides?
Yes.
Can you see my screen? Yeah, okay, fine. Wonderful. This is my disclosure. And yeah, of course, we talk about CLTI, about complex lesions. With the introduction of stents, we were able to treat successfully with a reasonable patency, also complex and long lesions. But now we are confronted with all the problems of in-stent restenosis and in-stent reocclusion. And we know with simple balloon angioplasty, we cannot achieve good results for this kind of disease. Because yeah, you have always this occluding material here still in the stent, which cannot be compressed into the arterial wall like a simple balloon angioplasty. And this is not an undersized balloon. This is the typical appearance here of ballooning of in-stent occlusions with the remaining occluding material in the stent, and subsequently with also a poor outcome in the long-term follow-up. About this problem, Tosaka already reported 10 years ago. He found out that especially in-stent occlusions have a poor outcome here if we treat them with angioplasty alone. So we need, for this kind of disease, other strategies. For example, a very plausible concept is to debulk the stent before any additional angioplasty or dark-coated balloon treatment. However, also these, let's say, standard debulking technologies like Hawking, like laser, for example, also showed no good results for the treatment for in-stent occlusions. If you look here at the patency rate at 6 and 1 years, it's a very poor outcome also of different treatment modalities for in-stent reocclusions. In Leipzig, we have a very long-lasting and good experience here with the Rotarex catheter. I think all of you are familiar with the device. It can detach the occluding material from the stent wall or from the arterial wall, then aspirate the occluding material, fragmentate it further, and transport it out of the body here by this Archimedes screw. And this is a little overview. We have a lot of evidence about the Rotarex. Meanwhile, and I want to point out here the one publication for the treatment of stent occlusions with the Rotarex device with 128 patients. More than 50% of the patients has the CLTI. Showing the complexity also of in-stent occlusions in these patients, with a good technical success rate here of 92%, and also a remarkable rate of MIA at 30 days and also at TLR at 20 years. So this is just one example for in-stent occlusions. This is also in confirmation with our results of our registries in Leipzig. Especially for the treatment of in-stent occlusions, I want to point out that it's reasonable to use the 8 French Rotarex, because it's the bigger device. It is able to remove even more material out of the stent in time, up to 75 milliliter of occluding material per minute. This is very remarkable, and this is outstanding compared also to other debulking devices which have not this high capacity really to remove occluding material out of the stent. And just to give you also the application here in the clinical case, I selected is a case of a left SFA in-stent reocclusion. I did some time ago already. However, this is still very, let's say, in time. I would not use any other techniques nowadays, even do the same kind of procedure, the same style, the same techniques also nowadays, although this case is I performed some years ago. And yes, I will start the case now, which I put together with my colleague Sabine Sven.
Yeah, thanks very much. Good morning, everybody. It's a male patient in his mid-60s. He had worsening of his claudications a few months ago, and what we saw then is actually an in-stent reocclusion of his left SFA. We also saw some stent fractures there. He has some comorbidities, coronary artery disease, hypertension, diabetes, and also his brachial index worsened to 0.6. So we have here this occlusion of the left SFA. It's really the full stent length is occluded, so this is the distal re-entry. I brought in an 8 French Cook crossover sheath because we are planning to do some debulking with Rotarex. This is the runoff, 3-vessel runoff to the foot. Here you see the stent fracture, so that's an image of that. I then tried to pass with a wire the stents, first with a stiff angle terumo. So this is, I've had a little bit an issue to get out of the stent, but then I managed to get a loop, and then it was rather easy to go through with a loop through the stent fractures. I also brought through a 5 French catheter so that we are sure that we're actually intraluminal and not through the stent struts. At the end, it was also difficult to get in, and yeah, now we are through, and I changed to a V18 wire because we are preparing for Rotarex.
Yeah, okay. The plan is here now also to remove the occlusive material from the stent, yeah, with Rotarex, then treat maybe with drug-eluting balloons, the in-stent reocclusion, and maybe we have also to cover these areas of stent fracture with another stent, with different stent, different to standard 19-hole stent, maybe with a Supera stent.
How old is this stent reocclusion? Is that a rather recent, or is that a more chronic scenario here?
It's about 3 months.
3 months.
So it's in between, I would say.
Intermediate.
Yeah.
Yeah.
Do you ever do any pre-dilatation to allow the 8 French Rotarex to cross a very chronic occlusion? And what's your feeling on
Yes. Yeah, that's a good point. First, I want to show you again, because they raised the question in the previous case, how easy it is to handle the crossover approach here with the 8 French Rotarex. You can see here it can cross very easy with this 8 French crossover in this crossover sheath. Regarding pre-dilatation, yes, in very chronic occlusions, I pre-dilate at least the proximal part of the occlusion, because this is normally the most stiff part of the occlusion, and we need a little bit blood flow in this area to let the Rotarex work appropriately. However, in this case, I try to cross now first. I feel no resistance, so it's not very hot and old material. So in this case, I think it's not mandatory to pre-dilate. I think it's also very safe to have the 8 French Rotarex here in an in-stent occlusion. There's absolutely no risk actually for perforation, for example. And we are very confident that we are really in the stent, because the wire passed it with the loop, and then we can be relatively sure, or actually very, very sure that it's really in the stent and not behind.
I think we have to make sure again that we are all aligned with the rationale here. I mean, clearly, in-stent reocclusions probably are caused to a large extent by neointimal hyperplasia and regrowth of tissue into the artery, but probably the larger component of the total occlusion is then the appositional thrombus proximal distal to these culprit stenosis, which develop in those stents, maybe even in areas where severe stent fractures occur or elsewhere. And I think that's the concept here, to really make these procedures safer by taking the thrombus out and then being able to deal specifically with the neointimal hyperplasia with more mechanical means. Is that an approach all panelists, Dr. Lichtenberg, would you do that similar? Or
Yeah, definitely this is the same approach we choose in our clinic. I'm not aware of any other devices which can debulk in this way, like this Rotarex device in this case, and then also to combine it afterwards, after debulking with the drug-eluting balloon. I think this is the way to go nowadays. I think what we should highlight here again is that it is quite important to choose the right size of the Rotarex to really create the best channel or the most effective debulking. So 6F wouldn't be a good choice. So 8F is the perfect choice in this case.
So Sven, how many passes would you routinely do in such a case?
Yeah, at least 2 passes.
How do you control your distal wire position, by the way? Is that something?
Yes, Sabine taking care.
Okay, Sabina is the secret, I understand. Okay, but it's important to do that because, of course, the wire could move distal. It's an atraumatic tip, but still, at times you should watch out.
We made a loop actually of the wire tip.
Which one?
Disappeared, okay, but this is also some, safety thing. The loop will not penetrate. So sometimes if the flow from above is poor and you do rotarex in such 90-0 stents, you can see sometimes the stent collapsing. And that's an indication for the high aspirational strength here of this catheter. In this case, I think we created already a good channel. So there is enough blood flow now in the stent, so it will not collapse.
Maybe you can explain again when you would consider doing a predilatation. You mentioned you would do that sometimes in the proximal part to, for the inflow.
Yeah. You feel if the proximal part is very tight and very old occlusive material, then first the rotarex cannot cross so easy, and then you also have no blood flow from above. And then you feel that also the rotarex, if the blood flow is also leading to a cooling of the catheter. It can then become hot if you have not enough flow from above. And in these cases, even also when the stent collapses, then I would just open up the proximal cap with a predilatation.
It was, for instance, I showed the one case in my presentation where we did the in-stent recanalization of the iliac, occluded iliac stent in a retrograde way, right? And in this scenario, of course, you're missing the inflow from above. So that means there's not too much blood in the around the rotarex system. And in this case, actually, we've seen a lot of suction and of the stent. So if that's not easy to overcome, it might make sense to really predilate the proximal segment just to allow a little basic blood flow, which is essential for the cooling of the device. So this looks actually very good already. Yeah. But here you can see nicely what Sven means, right? That frequently, right at the origin of an occluded stent, it's typical, it's not always, but it's frequent that you see high-grade stenosis in this area, and this can act as a valve almost and prevent deep blood flow, and this would be the area where a predilatation might facilitate the procedure. So now, how's your next step?
Yeah, next step will be ballooning. The question is, should we do this with a distal protection, under distal protection or not?
Well, actually, the thrombus removal is quite impressive here, I would say. What does the panel think? Would you, I mean, if you go ahead now with ballooning it, I assume he's going to use drug-coated balloons. Would you consider distal protection, or would you just go without?
I would not use distal protection because you have intact prevocation, and most likely if you get significant thrombus washed down, then you can easily aspirate it later on. If you would have a one vessel runoff, it may be a different story.
We still see areas with obstructions here, but at least to me, it doesn't look like a lot of obvious thrombus which is remaining. So my impression is that the cleaning was done relatively well, and since the whole thing is more chronic, also even if there is a residual thrombus, it is likely better fixed to the vessel wall, so probably the risk is a little lower with dilating it. But Sven, you are the operator, you make the final decisions here.
Yeah, I agree. So that's why I'm just proceeded here with the DCB. It's an impact 6 by 120, and these are relatively big vessels actually. I inflated the balloon up to 14 atmospheres now. Patient doesn't feel anything. Yeah, now we balloon all the way up. I think with DCB 2 to 3 minutes per balloon. We ballooned all the way up here with the DCB. This is a 6 by 120, 3 balloons we used. Okay. Proximally, There is some residual stenosis, I would say.
Yeah, I think this is very interesting, because, this tells us probably a lot about the potential failure mode of the stent, right? That is, there seems to be a distinct lesion at the origin, which really probably is very high grade and rigid. That's why we see here the recoil. And of course, we don't know, but it makes it quite likely that a lot of the remaining lesion was probably either milder degree of residual stenosis or appositional thrombus. So again, I think supporting the concept here of removing most of that up front.
So the plan is now to use the Supera stent first to cover here the distal part of the stent with the fractures, as well as I think the proximal part. This is now just to have a spot vessel preparation here. This is a 7 millimeter balloon now. Yeah, I think 6 millimeter Supera is the appropriate size for this vessel. It's an outer diameter of 6.5. Stood and directly at the bifurcation.
Absolutely. I think this is really for people who
Sorry.
who like driving sports cars like.
So yes, thank you very much. I hope you saw the live case appropriately. There was some delay in sound, I think. Sorry for that. But I think the concept is clear. This is how we treat our in-stent occlusions. It's always the same: debulking with a Rotarex, treatment with truck-coated balloon, and then, if necessary, relining the stent in the areas of stent fractures. With another, let's say, different stent design, like the Supera stent, or with covered stents. And this is our way to treat in-stent reocclusions. And so, ladies and gentlemen, I want to summarize and conclude as shown that angioplasty alone, either POBA or DCB, is no good treatment solution for long in-stent occlusions. Debulking before every adjunctive therapy like truck-coated balloons is a plausible concept and definitely provides better outcomes for these patients. And the unique features of the Rotarex, that means it's applicable for acute, subacute, chronic occlusions. We can use it from the iliacs down to the proximal tibial arteries. Its high aspirational strength with achievement of always a substantial luminal gain, as shown here also in this example. Also, there's no need to use filters. This makes the Rotarex really the perfect device to treat these complex in-stent occlusions, and that's tool, a device that I definitely also use every day. Yeah, thank you very much for your attention. And yeah, I give back to the moderators, and I'm happy to answer questions if they are rising.
Thank
Hello.
you, Sven. Pramuk.
Yeah, Sven, thank you for congratulations for your case demonstration. I have two questions. Firstly, the Rotarex can remove the thrombus in the, medium-sized artery, but not in the small size, as far as I know. And if there's a distal embolization into the small artery, it's quite difficult to remove by Rotarex. You need to use something else, like a pre-number. So when you will plan to use, distal protection device to prevent distal embolization? And then my second question is, when the fracture stent coming, when you treat with balloon, how is the alignment after ballooning? Would you see by not only angiography, would you like to use intravascular ultrasound or not? Thank you.
Yeah, thank you, Pramuk, for these very good questions. Regarding the first question, this is always coming up, these questions about the distal protection devices. So we know from other atherectomy devices that they are embolizing to the distal vasculature in a very, very high percentage of cases. And some of them are recommended to be used in general with distal protection devices. This is not so for the Rotarex. The Rotarex has such a high aspirational strength. Did not show this in this live case, but you can bring 19-node stents to collapse. So high is the aspirational strength. So that means everything that you detach from the arterial wall will also be aspirated and not fall down and do embolize. So this is one point. This was also supported by our findings in our registry with the Rotarex, which has 50% also subacute and acute cases. And what we found was only less than 2% embolization rate for the Rotarex. It's also complex long occlusions. This is very remarkable. So that's why I always recommend not to use in general a filter for the application of Rotarex. Of course, it's always an individual decision. There are some exemptions. For example, if you have really a patient with the severe CLTI, with extended wounds, with a poor runoff, only one vessel runoff, of course, then you want to minimize every risk and want to protect this one vessel that's going down. Then you might consider to use a filter also for the Rotarex. Sometimes, if you have some remaining material which appears softer or easy to movable material which you cannot remove after several passes with the Rotarex, and you have to balloon this area, then you also could consider to use a stent, but only for the balloon, not a stent, to use a filter, but only for the ballooning, not for the Rotarex itself. So what this is are very, very rare cases, also a patient where you really have a hard contraindication for thrombolysis and you have only one vessel runoff. Then you might consider also to use a filter. But this is a very rare cases. So in general, actually, you don't need any filter here. And the second question was the appearance or the management of stent fractures. You saw in this case, there was quite remarkable stent fractures present. So you saw that the Rotarex is very safe. This was also an 8 French Rotarex, which has a bigger diameter. There were absolutely no problems with the stent fractures. And what we see when we see such a really high-grade fractures, then we consider always a relining of the stent with another stent, like a Supera stent, which has another design and which then can better handle the stent fractures of a standard 19-node stent. Because we believe that these severe stent fractures are also a trigger for restenosis and can induce restenosis. That's why in these cases, then we reline the stent either with a covered stent like a Viaban or with interwoven 19-node stents like the Super.
Thank you. Thank you.
Okay. If there are no more questions, I have one, but I would expect, and I will wait the presentation of Steven first. there is a small change in the program. We would like to anticipate the presentation from Sven, and then we will go with Mariano, and then with Sven again. So Steve, thank you for joining us, and very welcome, friend. And okay, you can go with your presentation.
Thank you, Marco, and it's always a pleasure to see all of you. I hope you can see my slides. Can you?
We cannot leave.
We can hear you, Stephen, but the volume is so low.
Can you hear me? Is that better right now? You cannot hear me?
Very low volume.
You can adjust the volume, Steven. Adjust the volume on your computer.
Pump up the volume.
I'm sorry. Can you hear me better?
Pump up the volume. Pump up the volume.
Your headphones are dead.
Yeah, they are. Perhaps you can move to the next one, and I will try to resolve this. We can move to the next speaker, and I try to.
Okay. So let's change again the program. Georgia, let's move forward with my presentation, and we will be back with Stephen after this. Specifically, can you hear my screen? I don't think so. Can you share me the possibility to share the screen, George, again, please?
We can see your screen, Mariano.
Yeah?
We already can see it, yes.
Okay, sorry. So we will discuss a little bit about a different topic. This is the role to use scoring balloon and DCB in treating BTK disease, arteries. This is a case presentation, a case-based presentation. This is my disclosure. The case is about a female of 79 years old with diabetes, dyslipidemia, hypertension, atrial fibrillation, coronary arterial disease, and bilateral peripheral arterial disease. Previous coronary revascularization by PCI and by CABG, and the previous contralateral lower limb revascularization, PTA, plus minor amputation. She was affected by left foot CLTI, Rutherford 5 class, TCPO2 was low, 18, and the Wi-Fi score was 131, with superficial wounds in all the toes. As you can see, I did an antegrade access in the common femoral. This is the CO2 angio that show a good profound and diseased SFA with the short occlusion and the passage between SFA and POP, and for sure diseased below the knee arteries. No anterior, no posterior. The only vessel was peroneal that finally feed through the anterior perforant, the dorsalis pedis that was also diseased and present a distal stenosis. And well, if we consider the angio, it seems a very poor runoff with a diseased arch and not so big, no too much metatarsal branches. So as always, the first attempt was on the luminal crossing, 4 French catheter and V18 guide wire that allowed me to cross all the SFA and POP and to engage the anterior tibia. The problem started there because the 4 French catheter was not able to advance into the anterior tibial, so I pre-dilate all the SFA. You can see till the ostium with a 4 mm balloon. The result was not the best because there was some recoiling, some residual stenosis. So I deployed stent and finally moved forward with a long 4 French sheath using the telescopic strategy. So I deploy a 6 French allo one in short allo one in the common femoral and long 4 French allo one in the anterior tibial, where I shift the O18 for an O14 guide wire and gain the loop, all the dorsal circulation till the loop. And without any predilatation now, I test the ultrascore balloon. It was a 2.5 150 that, as I said, without any type of predilatation, using this very powerful strategy of telescopic sheath, the balloon was able to cross all the anterior tibial, and after a while insisting and pushing down the balloon and supporting the balloon with the long sheath, finally the balloon was able to arrive in the foot and finally to cross even the dorsalis pedis till the junction with the arch. So at that point, I inflated the ultrascore. As you can see, slow inflation, slow deflation. Ultrascore is a scoring balloon with external guide wires that can impact the arterial wall. And in those cases like this, with a big amount of calcium, allow us to much better prepare the vessel, much better open the artery, gain the lumen, avoiding dissections. So it's for sure a vessel preparation strategy, but allow us to obtain much better result. And this was the first check. Now direct blood flow in the anterior with still some residual stenosis in the distal anterior tibial and in the passage with the dorsalis pedis, but good outflow or much better outflow. So we repeat again another dilatation and a little bit higher pressure with the same ultrascore balloon that was able to be back in the foot without problems. And finally, this was the check, much better result. So finally, we decide to use the Lutonix DCB in the dorsalis pedis 2.5 and 3 millimeters to cover all the anterior tibia. So we use 4 Lutonix DCB. The shorter one was used in the proximal anterior tibia. And this was the final result. Was, as you can see, direct blood flow in all the anterior tibia with acceptable outflow in the dorsalis pedis, and completely different situation compared to the beginning, where even if the arch was not dilated, we can now clearly identify much better outflow, a big number of much better metatarsal arteries. And when we compare the perfusion angio pre and post, we can see that we gain a lot of perfusion. We increase the perfusion. Following the graphics, we can see that the time improve, and the volume or the amount of blood arriving to the ROI area improve also. And the ROI area was specifically put in the forefoot, taking in account the perfusion after the metatarsal branches. So again, open the inflow, all the SFA, popliteal, the anterior tibial, and the dorsalis pedis, we were able to improve too much the perfusion for all the toes through this apparently diseased metatarsal arteries. So in conclusion, strategies: 6 French and long 4 French sheath were used in a telescopic fashion, as I explained, to help provide additional support, stability, and pushability to reach below the knee and below the ankle lesions. This is a strategy that every day I'm using much frequent because allow me to increase the crossing capabilities and reduce the number of devices, so saving cost, saving time, saving contrast, and improving result. For sure, scoring balloon was used to aid in crossing the calcified BTK BTA lesions and to provide predilatation. Scoring balloon is a vessel preparation balloon prior to DCB used. And finally, the drug-coated balloon was the successfully used in clinical sequelae. For sure, in a patient with these distal small calcified arteries, we always have doubts if to use or not DCBs. I personally believe there is no limitations in the distal arteries to use DCBs. The secret is in the vessel preparation. And with this, I finish, and thank you so much for the attention. I'm ready for the discussion and for questions.
Thank you, Mariano. Can you hear me well?
Yes.
I apologize for earlier on. Thank you, Mariano. Good to see everybody, and good to see Sven as well. Mariano, perhaps you could share with us what are the tricks in trying to use a scoring balloon when you inflate the balloon? Is there a specific way you inflate the balloon?
Yeah, there is a specific way, or at least I follow the indications from the company. The idea is to inflate the balloon step by step. Do not increase the pressure very fast, giving the balloon the time to properly open and to impact the arterial wall with these external guide wires that finally allow us to, in some way, crack much more the calcium or the fibrotic lesions and so on. The idea is to go step by step, 1 atmosphere every 30 seconds. For sure, it's difficult to stay there 1 atmosphere every 30 seconds, but for sure, the idea is to inflate the balloon slowly, to respect the nominal pressure, at least for the first inflation. And if personally, if I repeat the inflation for a residual stenosis, as I show, usually I increase a little bit more the pressure over the nominal pressure. And again, the idea is to deflate the balloon slowly, not just deflate the balloon without pressure, but just go back with the pressure slowly in the way to again reduce dissections.
And how about the sizing of the balloon? Is it the same if you use a scoring balloon versus another regular balloon? Because I think you used a 2.5, but I think probably the pressure was higher, so the balloon did look a little bit on the large size. Is that right? Is that what you did?
Yeah. This is a fantastic observation, because we cannot continue thinking to dilate the distal dorsalis pedis at 2.5 and the same for the proximal anterior tibial. So since I was testing the balloon, I continued using the 2.5, but for sure different pressures in the mid and in the proximal anterior tibial compared to the distal dorsalis pedis. And finally, what I did was to use the 2.5 in the foot, Lutonix 2.5 balloon in the foot, and Lutonix 3.0 in all the anterior tibial. So I think specifically for this case, could be nice to mix a 2.5 ultra score in the foot artery and 3 or at least 3.5 ultra score for the anterior tibial. But it was one of the first cases in which I was testing the balloon, and for that reason I decided to continue with the same balloon.
Yeah, thanks for that.
Yeah, we have the same experience that you show. In our institute, we think scoring balloon is very useful for heavily calcified lesion, for below the knee, and much better than the conventional balloon. What about your experience on the above the knee lesion? You use the scoring balloon in the above the knee lesion?
I don't have so big experience in above the knee, but I think ultra score and scoring balloon for itself are an excellent tool also in the SFA and POP, because the idea is to much better open the vessel, reducing the dissection problems. And if we respect this progression inflation, respect the nominal pressure, and maybe we can in a second step increase a little bit the pressure, will reduce too much the dissection for sure. So my experience is not so big, but I'm really a believer of the use of scoring balloon for above the knee as well for below the knee.
And what about the report complication of rupture artery when we use scoring balloon? Is that possible? Because when you got the hard artery and you balloon it, it can fracture or burst. Is that possible? I don't know who anyone has any report or not.
Honestly speaking, Pramukh, I have experience of broken arteries with almost all type of balloons, but it never happened to me with the scoring balloon. And probably, again, it is related to the caution we use when we inflate the balloon. Inflating the balloon step by step, you can hear if the patient feels pain or not. You can give time the artery to be dilated rather than to go so fast with the inflation, and finally when the artery is broken you realize it's broken. So honestly speaking, it's never happened to me with a scoring balloon. I don't know if Marco, Sven or Steven have any different experience of perforation with scoring balloons.
Not with scoring balloon. We have a small experience with with scoring balloon generally, but never happened. I remember some cases with the cutting balloon of perforation, and of course, especially when you increase the size, it could be dangerous for the art.
Cannot hear Marco. We cannot hear you, Marco.
No more?
Yeah, now again.
Okay. So no, not at all. I don't know if Sven or Steven have different experiences.
No bad experiences with the scoring balloons. I think I mean, the concept of the balloon is to use rather lower pressures, and if you choose the size of the balloon appropriately to the vessel diameter, there should be no elevated risk of perforation compared to any other balloon. So that's and I use it quite a lot also above the knee. So I've never made any experience of vessel rupture by the use of scoring balloons.
Yeah, I think if it's going to rupture below the knee, it's going to rupture because it's a semi-compliant balloon, and there's a lot of barotrauma around the wasting point rather than just because it's a it's a scoring component. Because I mean, I've definitely ruptured vessels below the knee with a semi-compliant balloon because of the wasting of the severe calcium and excessive barotrauma beyond. So if it's going to pop, it's going to pop. Not, that's my take on it.
Yeah.
Okay, so we can follow the first change and give the ball to Steven. Now we can hear you very well, and we are ready.
Thank you, if Giorgio can. Yeah. Okay, can you see my screen?
Yes, you can.
Yeah, okay, thank you very much. Once again, thank you. Great to be back here again, and thank you, BD, for supporting this educational event. Just to follow on from Sven, this is my take on atherothrombectomy, the use of a dual functioning device. Real world requirements, I like to look at it in terms of native and stented vessels. For native vessels, we can have occluded vessels from embolism, from atrial fibrillation from the heart, and these embolus are typically platelet rich and full of white thrombus, or we can have thrombosis from a slow flow state, and I will have some examples to illustrate this, and these are usually a regular red blood cell rich red colored thrombus. And last but not least, in the native vessels, we can have atherosclerosis or atheroma. Within the stented vessels, we always talk about neointimal hyperplasia, or the sponge that we see, at least in open surgery. Within the background of both native and stented vessels, it's important to know that even in the patient with atrial fibrillation and the white thrombus, there's always a component of a red thrombus mixing with the white thrombus. And certainly in a patient with stenosis, there could be an element of soft clot in an atheroma as well. I will definitely move through this slide very quickly because Sven has already covered, and I'll illustrate the concept with several cases. So this is a case of atrial fibrillation and embolism. So this is our patient, an 80-year-old female. She's dialysis dependent. She has been diagnosed with calciphylaxis. So this is actually a bad patient with severe calciphylaxis, right critical limb ischemia 2 years ago. The SFA was stented with a drug-eluting stent, and spot stenting of the anterior tibial artery was performed. And she presented with rest pain on a background of neurogenic pain, but clearly dusky toes over 2 weeks, and the symptoms were not quite acute in nature. So this is the angiogram, and prior to this, actually, I'd like to say that the aortic bifurcation was quite difficult, and it was unable to administer an 8 French sheath. So this is a 6 French crossover sheath, and clearly there's a thrombus sitting in the classical area, the proximal superficial femoral artery, as well as profunder bifurcation. I then moved on to interrogate this thrombus with a 6 French rotarex. Of course, this video is extensively sped up 8 times. And within the area of the In-Stent area, there was also In-Stent restenosis, and we utilized the dual function to the rotarex to remove both the atrial fibrillation from emboli as well as the neointimal hyperplasia within the stent as well. Guide wire discipline is important to try and make sure that we maintain guide wire access. This helped to unmask the underlying stenosis, and then subsequently we did discover, however, that there was actually slow flow. I'm not able to fully appreciate if this slow flow was present before or after, but clearly there was some debris in the distal vasculature. This was summarily treated with an export catheter or a suction catheter in the tibial peroneal trunk. And this was in the anterior tibial artery. A similar procedure was done with an export catheter from Medtronic to suck out the thrombus. And we were able to get improved flow, some stenosis in the proximal. We utilized the distal clot to blow the stenosis and then aspirated again. We were able to restore 3-vessel flow. Now, the distal popliteal beyond the stent seemed to have some irregular area there, and we were uncertain if this was embolus or a thrombus. So again, a rotarex was performed to try and remove this soft clotting area all the way down into the distal P3 area. On occasion, we do put it into the TP trunk, but not in this case. In the magnified view, you can actually see some irregularity within the wall. This is a 4mm spider filter that we use, and sometimes we use this technology to actually do a Fogarty with the spider filter to remove that thrombus in the P3 that we could not take up with the rotarex. So using the spider filter as an embolectomy catheter to pull the thrombus up, and then as you can see, the thrombus is clearly within the filter. We were able to retrieve this white material that was probably adherent to the wall of the vessel and get a good result in this case. Again, we applied the same filter again and subsequently treated this In-Stent area with DCB and captured the filter. And then I think we were able to get a pretty acceptable result, not only in the SFA, but also the bifurcation. Some residual thrombus in the profunder artery, but we decided to leave that alone as long as we've restored flow. No stenting or excessive ballooning in the proximal area. Control angiogram a week later, because we had to treat the contralateral leg, the flow was rapid. No intraluminal defects that we could see that were flow limiting, and we did not do any severe BTK ballooning because it had only been rest pain, and the outflow was a tarsal artery. And I think in a patient with calciflexis, we try not to balloon too many arteries to keep our options open. The second case is a patient with a thrombotic event. So this is a 60-year-old male with pretty bad risk factors, diabetes, hypertension, history of short distance claudication. He had been a smoker. He came in with acute myocardial infarction and cardiogenic shock, required an emergency coronary artery bypass 3 vessels, and post-bypass required intra-aortic balloon pump through the right groin for 3 days, persistently borderline blood pressure, 90 systolic, requiring inotropes to raise his blood pressure. And of course, he had a very stormy post-procedure recovery, and after he woke up, he complained of breast pain and dusky first toe 1 week after coronary artery bypass. The CT scan shows unable to tell us if some of these lesions are chronic or acute. Certainly, with a history of claudication, we see a lot of collaterals on the right leg, and likely there's actually a chronic disease there. But on the angiography with a contralateral approach, you can see that these are chronic lesions, but possibly an acute component in the popliteal area, as well as some tibial vessel disease as well. Peroneal runoff and a posterior tibial. So the chronic occlusion was crossed not so difficult with a balloon and pre-dilated. So we think this is a chronic occlusion. And then immediately after that, it seemed that we were able to restore flow but still insufficient, and we had to tackle this P3 occlusion with the shadow in the popliteal artery. So we crossed the lesion with the O18 wire into the posterior tibial artery and moved on with the Rotarex device, thinking that this patient already had a low flow state, and very likely from the intra-aortic balloon pump with the background and SFA occlusion, this could be a acute on chronic state. So this is a 6 French Rotarex. The 8 French was also difficult to put in because of, again, the small vessels I find in our Asian population that is quite difficult to manipulate an 8 French across the bifurcation. Pre-dilatation, we were able to get restored flow, and because we think that actually the popliteal lesion was also a chronic lesion, after below the knee ballooning, we subsequently went on to apply a stent into the distal popliteal. Prior to that, we wanted to preserve the vessels in the peroneal artery, so a double wiring technique was performed in the peroneal artery. As in this case, we ballooned first the proximal peroneal artery with I believe, a 2.5 millimeter balloon, and then using another O14 wire through 2 O14 wires through a 6 French compatible drug-eluting stent. We stented the distal popliteal into the distal SFA, and then did some post-dilatation to allow stent expansion. Proximal lesions in the proximal posterior tibial were treated with a coronary drug-eluting stent. As you can see here, first coronary drug-eluting stent being applied is a Proma stent, and then retrieval of the wire in from the peroneal artery with a good flow there. Further down in the mid-posterior tibial, there was actually recoil even after a 3 millimeter high-pressure non-compliant balloon, and this area was again stented with 2 coronary stents to optimize lumen gain. At the end of it, we did have some wire spasm in the distal posterior tibial artery, but we pulled out the artery, and we anticoagulated the patient, kept the patient on a slightly higher blood pressure with inotropic support, and then and this is the Doppler signal the next day, and the duplex scan shows a wide open SFA as well as a peroneal artery as well as a posterior tibial artery. The last case I believe I have is an in-stent occlusion, and maybe I'll just give some slight talk on some things about why stents fail. It's either due to poor stent expansion from the original implantation, stent fractures, and last but not least, neointimal hyperplasia. But what we do know within acute stent failure is that you can have chronic stent in neointimal hyperplasia, but you can have also soft clot within the stent. This is an example of an occluded stent removed where we saw soft clot in an area of a drug-eluting stent and neointimal hyperplasia on the superior. And for those who haven't seen a neointimal hyperplasia, this is what it looks like. In some of these patients where we have to explant, in this case, you can see severe neointimal hyperplasia within the stent. Some of these patients, even after multiple interventions, have to have the stent explanted through a surgical procedure like that, followed by a fempod bypass. But when do we know it's acute or when do we know it's chronic? It's really quite hard to tell. Some of the literature out there seems to suggest that in acute stent thrombosis, it's quite quiet and silent in presentation and can have some neointimal hyperplasia and some soft thrombus as well. And some of these thrombus, if untreated, could be a barrier to drug absorption as well as embolism on implantation of the drug-coated balloon. So potential benefits of debulking are to improve the lumen gain, remove the soft clot, reduce the risk of distal embolization, and improve the drug absorption. There is some data out there on several single standard registries of rotational debulking and drug-coated balloon, but by and large, it seems to have very good 12-month primary patency by duplex ultrasound. An example of a patient with a chronic in-stent occlusion was treated as per Sven's case. Proximal tree dilatation was performed after crossing with a loop. Intravascular ultrasound, you can see the spongy material inside there. And this patient, after rotational debulking, a fairly decent lumen, and on intravascular ultrasound, clearly a much better lumen and removal of that spongy material, a drug-coated balloon, and in our experience, in some cases, we're able to use a combination of rotational debulking and drug-coated balloon to have almost a 3 years patency of an in-stent stenosis. A last case of acute stent thrombosis, a patient with renal failure, transcarotid TAVR done, SFA, chronic total occlusion, the full metal jacket 6 months ago. CO2 angioplasty. You can see that the stented area had occluded with the stump, and clearly in-stent occlusion with the anterior tibial runoff. The anterior tibial the SFA was crossed with a wire into the anterior tibial artery as per Sven and case with an 018 wire without the distal protection. This is a difficulty trying to get a 6 French rotothorax over the very tight calcified bifurcation that had been previously stented. With the rotothorax device, we were able to clean the proximal common femoral artery stent as well as the proximal SFA stent to remove it. Because this patient was quite a tall Asian patient. Sorry. This patient was quite a tall Asian patient. We subsequently moved on to do an antegrade puncture to try to attempt to clean the distal popliteal artery. So this is an antegrade puncture through the stent of the common femoral, and then passing the rotothorax through the antegrade approach. And then you can see the after a rotothorax, we'll be able to clean this whole area with the rotothorax device to remove all that thrombus. Subsequent to that, we were able to unmask that the underlying lesion was distal to the drug-eluting stent. It was probably missed on the first time round. This area was summarily treated. I can show you the angiogram in a short while. So this is the lesion that was unmasked, and this patient was subsequently treated with the further extension of a drug-eluting stent after pre-dilatation, extension of a 4 centimeter self-expanding drug-eluting stent. And the final angiogram, we were able to restore flow down the SFA as well as the anterior tibial artery and into the dorsalis pedis of the foot. Clinical result, able to do a 4-foot amputation. And in about 2 months, this patient completely healed up with a good duplex ultrasound, as you can see in this case. So in summary, we need a flexible device to allow us to treat heterogeneous pathology that we see in our daily practice. A mixture of arthrectomy and thrombectomy with a rotational device is well suited to meet this. Thank you very much for your attention.
Thank you, Steve. Fantastic presentation. I have just one question to you and to Sven about the use of this device. Assuming I was completely beginner with absolutely no experience with the rotational device like the Rotarex device, which kind of tricks and tips and tricks you have for me? In summary, what can I do? What can I cannot do? And what I don't have to do with the Rotarex device?
This is a loaded question, Sven.
For safety, just for safety. The first time I take in my hand the device, this is appears in your hand as usually a fantastic device, but if I don't have experience, where I have to focus my respect to the device, of course.
Yeah, I mean, Sven already showed us a lot of indication where we can use it. I mean, it was a nice example, especially the first case. It was a combined case of an embolic occlusion together with a chronic hyperintimal hyperplasia. Both pathologies can be treated with one device. This is very unique. With the experience, we also used it a lot in calcified occlusions, in fibrotic occlusions. I mean, from my side, where you should be cautious is if the artery is too small in relation to the device diameter. So that's for me the only contraindication. If the artery, especially for the 6 French device, should have a diameter of at least 3 millimeter to use it safely. Because if the diameter of the artery is smaller than 3, because of the high aspirational strength as reported before, you are on risk that you aspirate also the arterial wall into the head of the device, and this might of course lead to rupture, to damage of the vessel with a perforation. So that's for me the main exclusion criteria to use it. It's too small vessels. But calcium is no contraindication. We know that most of the also very calcified appearing occlusions contain a softer material in the middle. This can be treated. You should be cautious if the guide wire is also deeply subintimal. If you're really in a very deep arterial wall after subintimal recanalization, yeah, then you should also probably not use it as a beginner. But thanks to Sven again for this nice presentation, but you made me very thirsty actually, seeing all these bottles behind you. You're a lucky guy. So
from our experience, Marco, we have been using this one for several years, Rotarex. The indication is when you face with acute embolism, like from atrial fibrillation or from the heart. It's good device, especially for patients suffering with Rutherford 2B. We don't need to use thrombolysis. We use thrombectomy device. It's quite effective compared with the surgical embolectomy. Another advantage is if the embolism occur more than 24 hours. Usually the forcing catheter cannot remove the thrombus or embolus effectively. We need to use intraoperative thrombolysis. So microthrombectomy is quite safe because the thrombus is stick to the intima of the artery. So it can remove quite effective, better than the conventional surgical embolectomy. Another indication is acute thrombosis. We can remove the thrombus first. We don't need to use thrombolysis, and then we can use endovascular balloon or stent after we remove the thrombus. And another indication is acute graft thrombosis. We can use this one, and then when the graft is patent, we can correct. Usually the distal anastomosis is a major problem. And also, I want to know that from your experience, or Stephen, because I used to use Rotarex in the chronic emboli, like the 2 or 3 months. It's still working, because usually something like that, it's hard, nearly fibrosis, but Rotarex can still remove. But the majority is, one is arterial embolism, second is arterial thrombosis, the third one is graft thrombosis. Yeah. And then I agree with Sven that the infra below the knee is not effective. SFA propitial is effective, but below that we usually use something else, like pre-number can use like because it's small artery.
Probably just 1 or 2 quick comments from me. I think if you're starting out this device, it's probably best to use it as an in-stent scenario to, in a sense, get more experience with the device. And the second comment I have is, and I always remind myself before I start a case, is always go slow. Always go slow.
Actually, Rotarex can use in massive pulmonary embolism also, because when we put into the pulmonary artery, we can remove effectively, and we don't need to use thrombolysis, particularly for post-operative massive pulmonary embolism. The patient nearly die, but when we put the catheter and remove the thrombus, we can save a lot of patients. But be careful in the vein. When we suck it, it's bleeding out of the catheter. We need to replace blood immediately, unless the patient have a hypovolemic shock.
This is for the great capability of aspiration.
Yeah.
Yeah. Okay. Thank you.
And
Thank you very much.
Some mechanical thrombectomy device like angiojet, we need to aware of we call intraoperative hemolysis. You know, the red blood cell is rupture or something. We got thrombolysis. I got renal failure. So it's quite important to make sure there's another complication of some kind of this mechanical thrombectomy device.
Okay, thank you. So we can go ahead. We need Sven now, correct? Okay, Sven.
Okay. Can you hear me and can you see my slides?
Yes.
Okay. Yeah, it's my great pleasure to have the opportunity here to present another live case, or a recorded live case, of course. In this case of a native SFA occlusion. This is my disclosure again. This case I did 1 year ago with my colleague in Leipzig. It's a 60-year-old male patient. He presented with a bilateral claudication actually, but the leading side was the left leg with an ABI of 0.54 here at baseline. He had also a treatment of a AAA with a fenestrated graft 3 months ago. And this was also the onset of claudication. So actually in subacute, so I would say subacute onset here of, or subacute case. Here's the typical risk factors here, and this is the baseline angiography. With the, you can see this here with the left SFA occlusion. There's a little proximal stump of the SFA on the left side, and then a long occlusion. We can see this better later on in the live case. This was here the EVAR procedure with the fenestrated graft, and of course in this patient then with the extension of the legs and the iliac arteries, there was no crossover procedure possible anymore, which is actually our standard approach for femoral popliteal occlusions normally. So in this case, also with the presence of, let's say, patent proximal SFA stump, also an antegrade access is reasonable, which was done here. The plan was to pass the guide wire intraluminally in order to be able to do a rotational atherectomy with the Rotarex S device, followed by treatment with truck-coated balloons. Here again, the proximal and distal aspect of the left SFA occlusion. You can see this here again, long occlusion. Actually, this is already here the popliteal artery. And if you look here, actually not so much calcium present. That's why we also did not expect too many difficulties to pass the guide wire here through this occlusion. However, it turned out that it was very difficult here to even to get the access to the occlusion to pass the entrance of the occlusion, starting with 018 guide wires, going then to hydrophilic larger guide wires, also by the help with angled catheters. It was not possible to do really an intraluminal passage of the wire. Only subintimal wire passage was possible, and then additionally distally it was also not possible without the use of a re-entry device, for example, to enter back into the true loom with the guide wire, as shown here. And in these cases then we use a retrograde puncture relatively distal puncture here. Needle was almost too short here to reach the distal SFA, and then by using this retrograde approach, the usual way with retrograde passage of the guide wire through the occlusion, snaring of the guide wire, flossing, and then antegrade wire passage was possible. And at this point of the procedure, I want to show you in the video also for the application of the Rotarex device here. In this case, you can see here the whole video starts earlier, so we had to spend 40 minutes only. Oh, sorry. We had to spend 40 minutes only for the crossing of the guide wire before we can start with the actual treatment. We'll run now. Sorry.
Finally, I managed to pass the guide wire through the occlusion. I did additional ballooning proximally, and then the antegrade guide wire flew through the whole occlusion. So we exchanged now to 6 French sheets. You see here the 6 French L1 sheets is in place.
Sorry, some issues here with the sound. Let's try again.
So this is the break for the guide wire. This is to block. All right, Sven, I think we give.
Oh, Jesus Christ.
Here, again, nobody looking at works. The managed to pass by to the whole occlusion. So we exchange now to 6 French sheets. See here the 6 French.
I'm not sure, Marco. The sound is not good, right?
No, it is not. Unfortunately,
it's not good. Can you hear me? So maybe I comment by myself.
Exactly. Maybe it's a much better idea. Thanks.
So can you hear me? Can you hear me?
Yeah, we can hear you.
Yes.
Yeah. It's a pity because there was already a lot of questions here during this live recording. However, yeah, I can comment on this. You see here how I hold the device. I mean, I hold it always straight here, the handle, that the blood flow into the collecting bag is facilitated, supported by gravity actually. So it makes it a little bit easier than to collect all the aspirated material into the bag. The device itself here, it comes with a foot switch as well, with a switch on the handle. So I prefer to use the on-off switch here on the handle, because I have this in my hand anyway, so I can press the switch as well. And this is something here. This is the typical movement of the device. This is what Stephen already emphasized, to be slow. This is very important, really, to do it slowly, really to give the device enough time to aspirate everything into the catheter. yeah, that's one crucial point. If you are too fast, then you're just pushing material downstream, then with a subsequent risk of distal embolization, and this has to be avoided. So you can see here, I hold the system always straight, yeah, in a straight way. If you are a beginner, it's also advisable that you do the procedure together with another operator, concentrating on the guide wire, holding the guide wire here to prevent the guide wire from uncontrolled traveling distally. And yeah, and to do it in this fashion, like demonstrated here. So this is a typical appearance here of a correct Rotarex procedure. Again, you can see here it's not so much calcium, so very surprising actually for us why the guide wire was not able to cross more easily here, and we need a retrograde puncture, but this is underlining again the complexity actually of the case. Yeah, it's important also to go through the complete occlusion, through the entire occlusion down to the healthy segment. If it's a more fresh occlusion, so you can leave the last centimeter of the occlusion there before you go completely through and do an additional proximal cleaning again. This is also like distal embolic protection, leaving the last centimeter of the occlusion, the distal cap, and do first an extensive proximal cleaning. Typically, I do 2 passes of the occlusion, also like in this case, before I check the result. And again, you see here nicely the typical movement of the catheter, how you should do it slowly, and a little bit in, come back again, go in, come back, like demonstrated here. You get also, of course, this audible feedback, the sound of the motor. So if the motor is continuously running without change in sound, so you can be sure that there's a softer material. If the sound is changing, like the motor comes to resistance, then you hear this, and then you should be even slower, because then you can expect harder material where the catheter head needs probably a little bit longer time to ablate it. So, but in this case, unfortunately, you don't hear the sound. Was relatively easy. There was no change in sound, and the catheter went through continuously, like in demonstrated here. And this is also a very big advantage compared to other atherectomy devices. So you can continuously clean up your artery without the necessity to remove the catheter out of the body, to clean it, bring it back again, bring it out, clean it, and so on. So with the Rotarex, it's a continuous cleaning possible. If you look here again at the tube that goes to the collecting bed here, this you can check also continuously. You see here there's continuous blood flow. This is very important, and we had this already discussed in the first live case. Because the spiral is rotating so fast, it's 60,000 rounds per minute top speed. So it's a high mechanical force on this spiral, and this, of course, needs some cooling to prevent from overheating. Because if it's not cooled by a liquid like blood or aspirated material, liquid material, also, so then the spiral may become too hot, and then you're on risk for damage, for example. So it's very important always to check the flow into the collecting bed. So yeah, this was the Rotarex procedure itself, relatively fast now compared to the long time we spent bringing guide wire through the occlusion. And yeah, after 2 passes, then I normally check what luminal gain was achieved. So this is what I do now. And you can see here that's yeah, a little bit proximally dissection, yeah, but compared to the stump of the SFA, very nice luminal gain actually. It's bigger now than the proximal part of the SFA. In general, this patient has small vessels, actually unusual small for a German male patient. Distally here, very nice result, very nice luminal gain. You can see this here. This is something we see typically after only 2 passes of Rotarex. So we achieve a very good luminal gain. Again, it's a very safe device. Also here, I assume that the guide wire was passed partially subintimally through the occlusion, but there is no perforation and nothing for after the Rotarex. And also here, I didn't use any filter device. And then we can check, we will see later on, the distal runoff is not affected. There was no distal embolization also in this case. Yeah, and our typical procedure here, also in native arteries, is then to use drug-coated balloons, like in the In-Stent occlusion. So this the same principle actually here also for native arteries. In this case, we used Lutonix drug-coated balloons. Yeah, a little bit conservative in this patient because of the small arteries. You see here the runoff, that's the evidence that we don't have any distal embolization. Like this. Yeah, and especially in this, I mean, that's a actually complex long occlusion of the SFA in a small vessel disease. I'm always concerned to put stents here in these small arteries because, first of all, I mean, it must be a lot of fibrotic material here because the guide wire did not pass easily. And then with this fibrotic material, sometimes the opening of the stents is not so good. Small vessels, and then this might lead also to early restenosis reocclusion in these cases. So that's why I prefer not to stent, even if you have a long occlusion, but rather do this principle of debulking, as I said, followed by drug-coated balloon angioplasty. So that's for me a plausible therapy concept. And this is what we did here again. So we only used 4mm balloons, drug-coated balloons in this patient, which created already a lot of pain in this case. Yeah, of course, you can do some kind of local anesthesia around the artery. It's also possible really to get a better, maybe better diameter, better lumen with bigger balloons. However, pain also is, in my eyes, also a sign that we maybe not to increase the diameter of the balloons, because this is like a signal that we are close to rupture. Already then in this case with 4mm, you see he's moving, and yeah, this was painful for him actually. Yeah, and then we did Lutonix ballooning all the way up. It's another discussion point actually, whether we should do additional pre-dilatation after the Rotarex debulking, or should we do a vessel preparation with scoring balloons before the application of drug-coated balloons. According to my experience and looking at this case with this very good luminal gain after Rotarex, so I actually don't do any further vessel preparation. I think with the debulking after Rotarex, it's enough vessel preparation, so I go directly with drug-coated balloons, and no any additional pre-ballooning with POBA or scoring balloons. Yeah, maybe we can accelerate this a little bit. Not sure if this, let it run. Maybe better than try to accelerate and then we have a problem again. Yeah, of course, this is the DCB takes some time. Maybe I can answer some questions meanwhile.
Yeah, I have a question. Which is the reason why I must or I should choose Rotarex? I mean, you start your first presentation talking about different atherectomy devices. So which are the advantages that should allow me or must allow me to decide to choose Rotarex?
Yeah, that's a very good question. I mean, the main reason for me, or not one of the reasons first, is it can treat different pathologies. So this is a more chronic occlusion, but how sure can I be that there is not also soft material within this occlusion? So with the Rotarex, I can safely both pathologies, the chronic hyperplasia as well as the softer positional thrombus, let's say, like this in this occlusion. The second one is I can continuously clean here the artery without the necessity to clean the atherectomy devices like the Hawk, for example. Another reason is I don't need any distal embolic protection device. Which is recommended to be used with other atherectomy devices in general. And first, and another one, if I expect a lot of soft material, so I have no issue with time limitation, with hemolysis. So actually there is no time limitation as well of the Rotarex device, so I can use it all the way. And although you aspirate a lot of material and a lot occluding material, and the collecting bag always looks full. In fact, I have never seen any issues with, let's say, the need of blood transfusion or drop in blood pressure or some, let's say, problems with the circulation of the patient. So many special features of the device, which makes it my device of choice. Also in these cases of native artery occlusion.
I think
we can.
Sorry, I think Rotarex is different from atherectomy mainly because Rotarex is, I think, call it a thrombectomy device. It's been remove the thrombus or embolus, but atherectomy you remove the atherosclerotic plaque, so you remove the part of the wall of the artery. But whenever you have intraluminal thrombus, you use a thrombectomy device like Rotarex or any kind of thrombectomy device. Yeah, something like that.
I see this a little bit differently, because I mean, okay, the initial indication, let's say 20 years ago, of the Rotarex was to be used as a thrombectomy device alone. But with increasing experience, we learned that it's also working, let's say, in more chronic occlusions, that it's also able to remove organized material like intima hyperplasia out of the artery. Of course, it has no mechanical blades which scratch on the arterial wall directly, but the vortex which is created at the tip of the device is so powerful that it can detach also organized material from the arterial wall. Like shown in this example here, I mean, that was a phenomenal luminal gain here after the Rotarex, which was apparently no soft material. This was fibrotic chronic material. This is also the pain of the patient that was only 4 millimeter ballooning is an indicator that there is no soft material, that it's really intima hyperplasia of fibrotic material. And this we have learned can be also very effectively removed with the Rotarex device. It's not a thrombectomy device. It's also, let's say, a debulking device that can work like an atherectomy device. Also, it's not scratching directly at the arterial wall. That's true.
Let's say when you see intimal hyperplasia after procedure, you use Rotarex or balloon. Usually for stenotic lesion like intimal hyperplasia of the anastomosis or any stent, usually we use balloon. Is that correct? But not Rotarex.
I mean, I use Rotarex for occlusions. I don't use it for stenosis. I mean, for stenosis we have the boring balloons. So we have look at this here. This is a nice example. After ballooning, you see the proximal patent part of the SFA, which is still diseased and which probably also needs some more treatment. But from here, the occlusion started, and this is okay with additional ballooning with 4 mm balloon, but I would say a very remarkable result. And, after only 2 passes of the Rotarex, followed by truck-coated balloon, bigger diameter than the previous SFA above, and then the comparable to the SFA below, like shown here. So yeah, I think that's I mean, it's a nice example to see how effective the device is also in occlusions with chronic occlusions with organized material.
So when you mean you use Rotarex for complete occlusion, right?
Yes, sure.
Yeah.
For the complex.
Yeah, okay, I see.
I don't use it for stenosis because
Yeah.
I mean, for you could use it, yeah, sure, but I think it's more apparent the effect really in complex lesions, like in long occlusions, for example, like in this.
I think the reason can explain is maybe that complete lesion is maybe that static lesion is associated with the clot, intraluminal clot, can cause complete occlusion. Probably that's why Rotarex can work that well. It can increase lumen, maybe that point. Because I feel if it's really fibrotic, it's quite difficult to remove it, from my opinion. And another question that I'm wondering that what kind of information of this patient you have, because it's quite small artery. Is that fibrotic artery or any kind of chronic inflammation of this artery? What kind of disease of this patient has?
Yeah, I mean, we expected because this patient, I said the onset of pain was 3 months ago. Probably he had some disease beforehand. Yeah, some acute component on this chronic disease was also present. But as I said, especially in this fibrotic or chronic occlusions, if you balloon with small balloons and the patient has already a lot of pain, I mean, that's not not fresh.
Yeah.
Okay, but let me do the conclusion here of the case. I mean, it was an interesting case, I think, because it was unexpectedly not so much calcium present and unexpectedly difficult to pass the guide wire through the occlusion. But on the other side, then the Rotarex treatment was very fast and very effective, with really a very good luminal gain here. It's a safe procedure because it was probably also at least partially subintimal guide wire recanalization, also from retrograde. Again, also for the native arteries, for me, it's a very plausible concept to do a debulking before the truck-coated balloon angioplasty, especially in this complex long occlusions where we know that with the long stents we have also bad results in the long-term follow-up. And particularly here in this patient, where we had a follow-up by duplex ultrasound after 6 and 12 months. There was no more claudication here. We also treated, of course, the other side, and especially left side, he showed no restenosis. So yeah, thank you very much for your attention. I hope this was an interesting case to discuss now.
Thank you to you, Sven. So, Mariano.
Just to finish the discussion, the previous discussion with Sven and with Steven and with Pramuk, I think we finally can underline the safety characteristics of this device that allow us to choose it more frequently than the others. I mean, you can treat 360 degrees of lesions. You explained perfectly why it's not only for acute or subacute, but also for chronic, and seems to have the safety profile, the better safety profile. That's correct?
Yeah, absolutely.
Yeah.
Okay. Any other question? Marco, comment?
Oh, the comment is that, of course, this device seems to have, not seems, has a really wide range of application, and in my mind remains a dream, because I cannot have still in my lab. In my mind, there is still a doubt, and when I have a native occlusion, like Sven showed us in the last recorded case, and we think there is no a large amount of calcium, so we suppose to have a thrombotic, a chronic thrombotic occlusion of the vessel mixed with fibrosis for fibrotic plaques with very the difference atherectomy device, I mean a jet stream, for example, are so huge. There is supposing to have both. Which are the advantages of the Rotarex, and which are the difference? Because probably we have to understand deeply this concept, because Sven underlined that the original indication of 20 years ago of Rotarex was a thrombectomy. Now is a atherothrombectomy, so it's much more similar to an atherectomy device, but it's not a completely on the other side. It's not an atherectomy device for calcification, like or Phoenix or any other atherectomy device. So the subtle line, the red line dividing the two devices, if I had both, when one and when the other one, is the calcium the red line or not?
Marco? Yeah. Yeah, okay. What we know is that even if the calcium appears circumferential and complete, there's in let's say 90% of the cases still some softer core inside, and this is applicable for the Rotarex device, and this is the big advantage of the Rotarex, because I mean, if I look at the jet stream, how can this device treat this effectively if there is also soft material? Effectively, there's only small aspirational channel. This is always recommended to be used only with filters, and when I used the jet stream, for example, the filter was always full. There was always falling something down into the filter. So that's in my eyes, because you never know what's in the occlusion then at the end of the day. I mean, it's not either calcium or either thrombus. It's always some mixture. It's very difficult to draw a red line of when to use one over the other. And the big advantage is that the universal indication of for me, of the Rotarex, that it can definitely handle the acute, of course, the subacute as well, but also the chronic. Yeah. This is something we learned over the years of time. We use it since 20 years. We had the first generation Rotarex. And then came the improvement of the second generation, which made some substantial improvements. And by the daily use, I actually really use it every day. So we learned that it's very effective also in this more chronic occlusions. Yeah. Of course, if you have, let's say, a 30 centimeter long calcium chunk, which you can only pass deeply subintimal with the guide wire, then of course it makes no sense to use the Rotarex. But the question, makes it sense to use another atherectomy device as well? If it's too much calcium, it's always a problem also for the dedicated calcium atherectomy devices to really get the, let's say, a reasonable luminal gain.
From our experience, we use a clinical presentation. If the patient comes with acute limb ischemia, either or emboli or thrombosis, I think if we see complete occlusion, occlusive lesion, we offer Rotarex. But if the patient comes with chronic critical limb ischemia and you see heavily calcified stenotic lesion, we prefer to use either, if we cannot balloon or stent, we can use atherectomy device. Roughly speaking, like that. But Sven have more experience than myself. He can also use Rotarex for maybe soft plaque occlusion. I never had experience like this. But from our institute, we use just remove the clot, the thrombus component of the occlusive, a complete occlusive lesion. But we may try, like Sven advised someday. If we got soft plaque, it may be possible. But usually right now in our institute, if we consider it's thrombus, we remove with Rotarex. And atrophic plaque, we use atherectomy device, something like that. But we try to follow Sven advice, maybe more effective. Yeah.
Thank you, Pramuk.
Steven, have you some more comment?
No further comments. Certainly, especially for In-Stent, I think Rotarex works very well.
Okay. So guys, what can we say at the end of this session? Mariano.
Well, let's say, as always, thank you to everyone, all of you, especially for Steven, that is very busy today, but found time to stay with us. Thank you, Steven and Pramuk. Thank you again to Imiti and to BD for the support and the organization. Let's promote the next sessions. As you can see in the slide, the next is February 11th. It's Friday. So the same time. So it's a kind invitation to see all of you again and to continue with this course. And okay, thank you also to you, Marco, for your moderation and your support with everything and nothing else. So have a nice day, have a nice evening to everyone. Bye-bye.
Bye-bye.
Thank
Bye-bye,
you to
everybody.
everybody.
Thanks.
Everyone. It was a pleasure as usual. Thank you again.